Okay, so this patient has a new order for an NG placement. We have, as usual, verified our orders, informed our patient, given him information about what we're going to do. We want to ask him if he has any difficulty breathing out either nostril. Maybe he's had a broken nose or some nasal surgery, or just for some reason simply can't breathe out one nostril. If he tells you he can't breathe out the left nostril, then you're going to choose the right, for example, and he'll say, but then I won't be able to breathe, and then you explain to him that, you know, he'll probably then at that point be breathing more through his mouth and compensating in that manner. Equipment is you're going to need a irrigation set, an NG tube, 16, 18. We're using a smaller one because these mannequins just don't tolerate a larger one. But dependent upon the reason for the NG, you know, like if you're going to be suctioning large particles, then of course you're going to want a larger NG tube. I need my stethoscope, and I need a pan for emesis. I need to pad my bed. I need a cup and a straw with some water in it for this patient then to be swallowing some water as I put the tube down. Some tape, possibly some type of skin prep, maybe then to prepare the skin around his nose so that the tape will stick a little better. There's other methods other than regular tape, and you'll see different types of supplies at different facilities. If you're just using plain tape, you'll just tear off a piece, considering so much for the bridge of their nose, and then tear it right up the center. Of course, my tape didn't tear straight. There we go. Okay, and I have cleansed an area here on my bedside table so that I can feel free to put this down. Put my gloves on, and the NG tube comes in a sterile package, but this is not a sterile procedure. The type that we're using is a Salem sump. It's a double lumen tube. It has, I mean, if you look at it, you can see the 2 lumens. It has several holes at one end so that it doesn't suck up against the stomach wall and adhere and cause, you know, like lesions in the stomach. And you can look down this end, see the double lumens. The blue tube is for air and air only. That also is a safety feature that keeps it from sucking up against the wall of the stomach. So just realize that you always want to keep this open, patent, so that it does have good airflow. And you won't be irrigating through this part of the tube unless you've got secretions caught in there that you need to get out. I'm going to go ahead and clamp this off, because when I put it down, once I get down to this patient's gag reflex, they may start vomiting, and if I've got the tube down there, then the emesis is going to come out the tube, and I don't want to wear it the rest of the day. So I need to do a measurement. The measurement, a little acronym to help you remember, is NEX. So we're going to go from the tip of the nose to the tip of the earlobe, and then down to the tip of the xiphoid process. This does have markings on it, but I'm telling you, in the heat of the moment, you want to make sure that you've got some tape on there, because you won't be able to remember which marking that you're at. I'm telling you that from experience. It's like, oh gosh, I don't know if I passed past the first marking, if I'm on the second one, and so you want to make sure that you have a piece of tape on there so that you know where you are. So I have done my measurement. I've got my patient in a high Fowler's position. I want him sitting up as much as possible. I want him positioned with his chin down on his chest, and then, well, excuse me, back up. When I first start, put his head back so that I'm going to go straight back to the back of the throat here. And once I get right to the back, it'll feel really stiff. And you just got to push a little bit harder. And then once you feel it go past that curve, then at that point, you tell your patient to put your chin on your chest, and he then is taking drinks with his cup and his straw, and you tell him to swallow. He likely will start to vomit, and you've explained to him ahead of time, you know, just hold on to this pan, because if they don't hold on to the pan, they likely will grab your hands, because it's a very difficult procedure. It's very uncomfortable, and they may grab your hands and try to pull away. And once I've got to this point, he's gagging, possibly, throwing up in the pan. I don't want to quit. I can't let go of this, or, the contractions he's having, as he gags is going to push it right back out. So I want to keep going. So rather aggressively, you keep saying swallow, 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 until you get it into your piece of tape. Okay, now I don't want to let go, because again, it will come out if I let go. I've got my tape ready. Go ahead and grab it. Take one and curl it around. I've got this thing kind of greasy and the tape won't stick real well, but the other, and curl it around until you get him taped down really good. Okay. Now, I tell you one thing that I didn't tell you, that certainly I would want to lubricate the tube with water-based lubricant before I stuck it down. It make it go a whole lot easier. All right, so I want to check for placement. I am going to check with 30 milliliters of air. Again, go down to the tip of the xiphoid process, and then over just a bit to the left, and push it in. I can hear the bubbling, gurgling sound, and I can also pull back, check for secretions. I can test it with some type of nitrazine paper, or some type of whatever the hospital supplies you with. And then I'm going to give that back, because what I'm going to do with him then is hook him to suction. Here it is, sorry. Oh, my fingers are greasy. Okay, so I've got a little connector here. Connect him to suction. And then, depending upon what the physician has ordered, a common thing is low intermittent suction, but I will set my suction regulator to whatever was ordered. Of course, I'm starting off with an empty suction canister, and I want to be here long enough until I know what his initial stomach contents were, so that I can measure that and mark my canister with the time and the date. And a lot of times there's it's made so that your ink pen will write on the canister real well, but if not, you can always take you a piece of tape and throw it on there and mark on the tape and write the date and time, and then you're going to document the amount, color, consistency of the gastric secretions. You're going to, of course, document how the patient tolerated the procedure, the size and type of tube that you use, like this was a number 14 Salem sump. Okay, so I also then need to make sure that this part of the tube stays up above the level of his stomach. If it gets down here and hangs below, it's going to leak secretions out the air vent and cause a mess. So if I try to keep it up here on the head of the bed, that's a good thing. Certainly I can take a piece of tape, put it around here, and then now take a safety pin and tape that to his gown, and that holds it pretty secure. In years past we may have taped it to their cheek, but it's just way too difficult and uncomfortable for the patient, so we just basically tape them and then pin them to their gown. The problem of this leaking gastric secretions is continuous because, you know, the patient doesn't just lay still like this mannequin. He's going to be up, he's going to be down, moving around. One thing that they've come up with in order to keep this thing from leaking is called an anti-reflux valve. It's got a little filter here in between the two colors that is supposed to allow air to go through and keep the secretions back, but it's not perfect. It will get clogged with secretions, and then you don't have an air vent. So that's a problem, and then they need to be changed frequently if you are using them. As far as maintenance of the NG tube, normally you're going to have an order or maybe a standing order that you're going to irrigate your tube every 2 hours with 30 milliliters of normal saline. If that's true, I'm going to come in the room, and of course my suction is already turned on. I'm going to leave it on, disconnect, and then, you know, because I've left my suction on, nothing will be dripping out of here. If I turn my suction off first and then disconnected, this tube would be dripping. So I leave my suction turned on, I disconnect, I should have done this first here, but I don't care. Okay. I draw up 30 milliliters, well, excuse me, let's do 30 milliliters of air. Anytime before you put anything down a tube, you always check placement first. That's very important to remember, that check placement no matter what you're doing first. Okay. So I'm listening over the epigastrum, push it in, and I clearly hear it. I pull back and get some secretions, so that's verification too. And again, I can use that third part if I need to, as far as checking with the nitrazine paper, litmus paper, whatever kind they have. So then I want to again draw up 30 milliliters of fluid, put it down, attempt to draw back, and again this just washes out the tube, keeps it patent so that it doesn't clot off and then not be able to get secretions from it. If I put it down and not draw it back, then I need to add that 30 milliliters as intake, but if I can draw it back, I don't have to add as intake. And each facility may do this a little differently. Their policy may be just to put the 30 milliliters down every 2 hours and not withdraw it. So, you know, you'll need to know your facility's policy. If this air vent has been leaking secretions, I need to clear the secretions from it, so I'm going to pull back 30 milliliters of air and flush it with air. Sometimes the secretions will dry in there, so it might be that I have to put some saline down it, so I might put 30 milliliters of saline, But the key thing is then once I've done saline, I'm going to follow it with air, because I don't want that to be plugged with anything. So I'm going to flush with air so that I know the air vent then is patent. After I have done this, then I can hook back to suction and continue on. As I said, very often you'll do this every couple of hours, 24 hours around the clock while the patient has this. Okay. Here is another type of tube that I like, because I never seen one that had its own caps on them. We improvise. We pinch the tubing when we want to keep the air out, but boy, this one has its own caps, and it's made of silicone, and it's a little more flexible, so I kind of like that. Sometimes if you have one that's too flexible, you may want to put it down in ice water to firm it up a little bit if it's you're having difficulty getting it in because it is too flexible. Okay, when you're ready to discontinue the tube, first thing you want to do, of course, is disconnect. Again, I'm not going to turn off my regulator until I have disconnected and it clears the tubing, the suction tubing. I then want to, before I put anything down my tube, I want to check placement. So I'm going to check placement with 30 milliliters of air while I listen over the epigastric area. I hear that. I pull back, verify secretions. I'm good. Okay. Now what I want to do then is draw up 30 milliliters of saline or water, depends, whatever you're flushing with, and flush the tube and then follow it with air so that I've gotten most of what I can get out of my tube. So I followed it with air. I can leave my syringe attached, and that is an adequate way to block it off. Or I kind of like this better, but whatever. This totally occludes the area. So anyway, so I've got it occluded. If you're not occluding by this method, then you would want to pinch off. It's a little more difficult to do, but certainly the idea is you don't want to be dripping gastric secretions on the way out. The highly acidic secretions, you certainly don't want to be leaving a trail as you pull out. So I undo my tubing, take maybe a washcloth or some paper towels, whatever you have. And I will say this very often has been down for maybe as much as a week. If the patient has maybe sinus drainage, this tube comes out and it's offensive for the patient to look at. So you want to kind of do this as quick as possible. It is uncomfortable, so we keep a paper towel in one hand. I'm going to pull, and again I'm going to tell him, take a deep breath in, hold it, and then I'm going to pull as I grab it and kind of then get it out of the way. Then at this point I want to have tissues to give to my patient to blow his nose. I certainly want to offer him oral care and get him cleaned back up. Okay, I think that's it. I think you guys have a 2-week check-off, so you got to get this done within that 2-week time period, so don't put it off till the end.